Slides are visible?
Yes,
Yeah,
yes.
very well.
Sure.
You're audible as well.
Thank you. Thank you for the nice introduction. And I'm going to speak on primary aldosteronism, intricacies in diagnosis and management. To introduce the topic, I'm sure we all know that it's primary aldosteronism is fast turning out to be the most common cause of secondary hypertension, and few experts say that it is becoming one of the commoner causes in the complete hypertension subgroup as well. When you talk of PA, we know about adrenal cortex, and I'm going to restrict to glomerulosa, which secretes aldosterone, which we all know, which leads to primary aldosteronism. Now, aldosterone was isolated in 1953, and in next 3 to 4 years, Jerome Kohn uh, described this classical syndrome of which is called as Kohn syndrome, where the patient came with hypokalemic paralysis, hypertension, metabolic alkalosis, and this was completely reversed with the adenoma excision, and journey of Kohn syndrome began after that. They've seen a lot of ups and downs, and the interest in Kohn syndrome has had resurgence since few years. When you talk of Kohn syndrome, immediately it comes to the mind that things are very difficult, and uh, we've always been taught in medical schools that it's very rare kind of tumors, and it's very difficult to kind of evaluate these tumors. But the basic concept is what we need to understand is that it works on two major players. One is renin and one is aldosterone. This is a low renin hypertension where aldosterone is autonomously high. So in the face of low renin, there's no business for the aldosterone to be there. And if the aldosterone is there, it means that it is coming out from the gland, which is autonomously secreting and needs to be out. So for describing our experience in diagnosis and management, few facts needs to be known. The first one is about pathophysiology. We know about this aldosterone, which works on mineralocorticoid receptors and leads to increased sodium absorption, volume expansion, and increased blood pressure, which ultimately would suppress the renin and angiotensin and would prevent the proximal renal, the tubular absorption of sodium. This leads to increased distal delivery and ultimately causes loss of potassium as well as H plus, leads to metabolic alkalosis. And all these pathophysiology is the one which leads to increased cardiovascular and kidney disease, which is the crux of primary aldosteronism, which we try to treat. It has been very clearly shown that if you compare patients with essential hypertension versus those of PA, and if you look at cardiovascular events and target organ damage in them, it's shown very clearly that PA will have more of these events compared to essential hypertension, independent of the BP control. With the same BP, they will have more problems, and this is aldosterone specific toxicity. And mind you, this high aldosterone alone is not really doing much of a damage. It's because of that link of sodium excess which exists with hyperaldosteronism in case of PA, which is responsible for this cardiovascular damage. So one of the most important strategy to reduce the morbidity and mortality is to restrict sodium intake, and you would have reduced a lot of damage of these patients when we really treat this patient. So it's one of a very important diagnostic as well as management issues which needs to be looked at. Epidemiology, as I was talking about, right from our medical schools, we've been told that this phenomenon is quite rare, less than 1% of total hypertensives. But more and more studies have really questioned this dogma and have clearly shown that it's not rare anymore. It's becoming one of the most common cause of secondary hypertension. This was a study in Italy where it was done in hypertension clinic, where they looked at uh, approximately 1,700 patients, and they used a two-step approach of looking at a screening test and a confirmatory test. Screening, they use a standard ARR or PAC by PRA ratio, which we call, and whoever positive were subjected to a confirmation test with IV saline, and of which 100 turn out to be positive. So the prevalence was deemed to be 6%. So definitely, which is what has been taught in books is not anymore true. Minimum, we talk of 6% of PA in a case of hypertension is a big number, and it depended upon the severity of hypertension, stage 1 hypertension to stage 3, where stage 3 it was around 12%. These things have also been replicated in other studies where prevalence has been around 10 to 20% in case of resistant hypertension. Even AIMS data, which is just published now, where they looked at young hypertensive patients, prevalence of PA was to the tune of around 20%. So we are all talking the same language world over as well as in India. and we need to know that we are dealing with a very common disorder which we need to screen. Guidelines tell us to screen only the severe kind of overt presentations, but those with milder hypertensions are not really looked at, and we may be really missing a lot of number of patients which may get their due credit if diagnosed properly on time, and the complications can be prevented. What does guideline tell us? That if you have a severe kind of hypertension, resistant hypertension with adrenal mass, or there are family history in a case of young hypertension, you need to definitely look at it. But more and more experts are coming to the term to say that in case of any case of hypertension, once in the lifetime of a hypertensive, we need to at least screen for primary aldosteronism, and it's not difficult to screen it at all. We just need to do a renin and an aldosterone level. With the availability of various assays which are chemiluminescence based, it's quite simple to do it, and it's worth the amount of money as well as the amount of benefit which we can accrue out of it. So with that background, let's look at how to diagnose them. We've earlier been using plasma aldosterone concentration as well as the plasma renin activity, which had been taught to us from earlier days, which were earlier being done by immunoassays. Now we have both these tests, aldosterone as well as renin in the form of renin concentration, available as a chemiluminescence technology, which can be very easily available, and they have a very fast throughput. It's like T3, T4, TSH being available in chemi assays, and it ensures that rapidly, when you talk of 6% of prevalence of hypertension and you need to screen so many patients of hypertension, you need a test which has to have a good throughput as well as fast kind of answers to that. And we would do the test in a screening mode first, followed by a confirmation test. So what are the nuances or what are the learning points I'm going to share with a few cases which we are going to see now. Let's look at this patient, first case, who is a 26-year-old lady who has come with recurrent episodes of hypokalemic paralysis, and because of that, she was put on aldactone, and the screening was done with PAC, the aldosterone as well as DRC, and potassium was 3.2. And the other patient, who is 52-year-old male who has got hypertension and who is on 3 drugs, losartan, HCT, and amlodipine. Aldosterone levels were 19, PRA is less, potassium is 3.9. The immediate question comes to us: how do we stop these medications, or how do we interpret? Whether can we interpret these values? We need to give high salt diet, potassium replacement, stopping the drugs for X amount of days, and that's where all the controversy starts. And then you realize it's not easy to do it, and patient may really leave the doctor if you try to do so many tests or try to stop the medications. The blood pressure goes up, and that's been a common practice. So that's how it has been very clearly shown now that what needs to be done is not to stop the medicines, and let's look at what transcribes out of it. When we do a screening test, we ask for renin as well as aldosterone, and as guidelines say, we have to do a ratio. Instead of looking at ratio, we have to look at these two tests separately. You look at plasma renin activity. If it is suppressed, then your diagnosis of low renin hypertension is made, and in that phase, if your aldosterone is more than 10, then the diagnosis of primary aldosteronism is clearly made. There's no reason why aldosterone should be that high in a phase of renin suppression. People want to take the level of aldosterone lower and lower to 6 and all with the latest studies, but at least 15 is definitely diagnostic, and definitely 10 is also a criteria which needs to be looked at of aldosterone levels in the phase of renin suppression, and ARR is not really sensitive enough to pick these cases. So when we talk of, as I was talking, it's always in our mind about prerequisite before testing for ARR. We need to do the test early in the morning. It's you have to be up and about. Patient has to be up and about for around 2 hours after getting up, and then you need to make the patient sit for 10 minutes and collect the blood for aldosterone as well as DRC. Ideally, try to normalize the potassium and liberalize the sodium intake. It may not be possible in routine scenario. Our diet itself contains a lot of sodium nowadays, and we are all having salt quite liberally. And about the drugs, most of the drugs which we are used as a treatment for hypertension will increase the renin, and only beta blockers and central sympathologics decrease the renin. So if you get a renin which is suppressed, in spite the drugs are going on, you can interpret the test. and you can don't have to repeat the test or stop the drugs at all. But if you are not sure, if the renins is not suppressed, and if you are very clear that the clinical suspicion is very high, then you need to stop the drugs for 6 weeks for MRAs and 2 weeks for ACE and ARBs. Definitely liberalizing salt intake further would add on. About confirmation test, there are myriad of tests which are available, but what we use is seated intravenous saline suppression test, where around 2 liters of normal saline is infused over a period of 4 hours with patient in a seated position, and we do various cortisols and aldosterone pre and post. If the post infusion aldosterone level is more than 6, the diagnosis is clearly made. Other tests like 24-hour urinary aldosterone level after giving oral sodium suppression is also one of the tests which has been advocated, where if your 24-hour urinary aldosterone is more than 15 microgram, 12 microgram per 24 hours, then the diagnosis is made. But mind you, experts want to make things very quite simple and not make it complicated. They think that confirmation test may not be required if there is a very strong clinical evidence of a severe kind of presentation where there is hypokalemia. If PRA is suppressed and aldosterone level is more than 20, then you don't require any confirmation test. Even one test is done, and you can go ahead and start treating the patient. So with this background, let's solve the issue with these two patients, the diagnostic based one. First one, this lady has hypokalemia. You have renin which is suppressed on aldactone. So if the renin is suppressed, you don't have to really stop aldactone. We accept that this is a low renin hypertension, and with such high aldosterone, more than 15, 10, whatever you take, it's primary aldosteronism, and you can interpret that. Diagnosis is made, and confirmation test is not required because aldosterone is more than 20. So we go ahead and straight away go for imaging. Imaging shows left adrenal adenoma, and she's subject to left adrenalectomy, and post-op she's really cured. When you talk of the second patient who's on 3 drugs, renin is suppressed. In spite of these drugs being there, if renin is suppressed, that means you can go and interpret this particular test as positive test, and then we go ahead and do a confirmation because the levels are not that high. Aldosterone level is less than 20 as such. That's a cutoff which is arbitrarily put there, and we do a confirmation test which says that it's not really suppressed. It doesn't get suppressed. That means PA is confirmed. Do an imaging. Imaging shows bilateral nodules, and the patient is put on medical therapy. So the crux of diagnosing is that we don't need to stop any drugs. We just go ahead and do renin as well as aldo. If renin is suppressed and aldo is high, your diagnosis is made and you can go ahead. Once you're biochemically confirmed, then we need to see where this autonomous aldosterone is coming from, and that's called as subtyping of the patient, where the cause can be bilateral in most commonly seen in 60%, or APA unilateral in 30%, and there are various genetic causes depending upon the age of presentations. And we would ask for CT scan and as and when required, adrenal venous sampling. What the CT scan tell you is that if you get a single adenoma on one side and no adenoma on other side in a young patient, then it's really diagnostic. But most of the time, you don't really get any abnormalities because bilateral adrenal hyperplasia is more common kind of scenario in the current world. So you may get mild bumps here and there on the left and the right, or that could be completely normal. And this is where you require an adrenal venous sampling to really sort out the issue, whether it's right-sided or left-sided or it's both-sided. We have established this technique, and it's running quite successfully for patient care at KEM Hospital, where a trained interventional radiologist who only does a single person who does this procedure repeatedly for years, and he's become very comfortable with that procedure. What essentially is done is the catheters are advanced through the femoral route to bilateral adrenal veins to the right as well as to the left. Cannulating the left one is easier, right one is a bit difficult, and we need to be sure that we are inside the vein, and that's how we look at then levels of aldosterone and cortisol from these sampling. So to know that whether these adrenal veins have been catheterized properly or not, there's a particular index which is called a selectivity index, which means that they would look at a cortisol levels from this adrenal vein and divide it by the peripheral vein cortisol. If it is more than 5 times that of the peripheral vein cortisol, that means the catheter is inside the adrenal vein, and you can interpret or analyze the aldosterone values which can be taken. So once you know that catheter is inside, then we look at the aldosterone values from both right and left, and we try to divide the higher one by the lower one, and that's called as lateralization. The higher aldosterone value from the side of that gland should be more than 4 times than that of a lower one, suggesting that there is an autonomous secretion from that higher side gland, and which is called as the lateralization index. And the third important index is contralateral suppression index, where the non-dominant gland is supposed to be completely suppressed. So it's going to have aldosterone values which are less than that of IVC or peripheral aldosterone. So if it's less than 1, when you divide that, then that's called as a contralateral suppression. And all these 3 indices are required are essential to designate which gland is the culprit and remove that kind of gland. What we do with us is we give a sequential adrenal venous sampling under continuous STH post-entropin infusion, which is started 1 hour before the procedure and goes throughout the procedure. And we do an intra-procedural serum cortisol confirmation, where the radiologist are waiting for the cortisol values during the procedure, which takes half an hour approximately, to get that value to see whether your catheter is inside, and then the blood is collected for aldosterone. So it has all been typed with us. Since it's an invasive procedure, it's done in expert centers as such only, but looking at the number of patients, many of the patients may not be able to be subject to adrenal venous sampling, looking at 6% prevalence at least to the least. And that's where experts say that if you have a clear-cut evidence of a severe case, then AVS may not be required, especially if you have a unilateral adenoma with no adenoma on one side and normal adrenal gland on the other side, with severe case and in young patients. Because as the age increases, then the bilaterality of the lesions as a normal physiology of aging starts increasing, and hence you may be wrong if you do not use AVS when the age is more than 35 years to begin with. So I'm going to show you cases now which we have managed at KEM Hospital, and give you a snapshot of it and give a learning message with each case what we have gone through. So look at this lady who is young and who has hypertension and hypokalemia. Biochemically, she is completely diagnosed as PA. Aldosterone is more than 30. Hypokalemia, young, less than 35 years of age. You do a CT scan, shows left adrenal adenoma. Right side is not showing anything. So this case doesn't require confirmation. One screening test is enough. This case doesn't require confirmation. And this case doesn't require any adrenal venous sampling. And you can go ahead and operate this patient. Post-surgery of left adrenalectomy, she was completely cured. One more thing I would like to showcase here is that we have shifted from open surgeries to laparoscopic surgeries, and from transabdominal surgeries to retroperitoneal surgeries, where the operative time and the recovery time is within 24 to 48 hours, and patient is able to walk by the end, by the evening of the surgery, with retroperitoneal approach. And the surgeons have really mastered that technique of doing retroperitoneal adrenalectomy, which is a need of the hour, because if you're looking at so many patients who would require treatment, then we need to have a lesser morbid procedure which needs to be there. There are a few learning from another different patients. This patient tells us something. So this is 38-year-old male who has hypertension and hypokalemia, biochemically proven to be having primary aldosteronism. If you do a CT scan, it shows that there is bilateral bulky adrenals, but you can see that right is not that bulky and left one is bigger. And you don't know whether it's right. So you don't know which side to operate. So that's where AVS is really required, to see whether this small nodule which is sitting there is a right culprit or not, and whether the left one, the right one is completely normal. So we do adrenal venous sampling, look at this data. Would like to simplify here that we, as I told you, selectivity index, we see whether the catheters are inside the adrenal vein or not, and it should be 5 times that of the peripheral cortisol. Both the adrenal veins have been catheterized quite well, 14 and 15. And then we look at the lateralization index. When you want to divide the dominant aldosterone value with the non-dominant one, and it's 21, which is more than 4 times. So diagnosis was completely made, and it has been lateralized to the left side. So though there was a clinical suspicion, imaging suspicion of the left kind of gland which was increased, and right was kind of mildly thickened. But we didn't have a courage to operate without an AVS, and AVS gives us a clear guidelines that you need to go ahead, and patient has improved with that. So CT was bilaterally symmetrical and AVS was unilateral. You could get that. Similar kind of information we got for another patient. Now this lady was having severe hypertension with accelerated hypertension, pulmonary edema with biochemical confirmation of PA, and you could see that there were bilateral lesions. Here, when you look at the selectivity index, it has been catheterized well, but there is no gradient. That means it's a bilateral adrenal hyperplasia, and she was treated on medical therapy and is doing quite well. Another case of similar PA where MRI, the imaging showed that there was a right adrenal adenoma and the left small nodule. And without AVS, we will not be able to really tell which was a particular part. So on this particular patient, there was a left small adrenal nodule which was secreting the aldosterone, and the right adenoma which was there, which was a non-functional adenoma, and that needed not needed to be removed. And so AVS gave us a very clear and confident diagnosis to go ahead and operate this patient. Post surgery, patient is doing quite well. Learning doesn't stop. Every patient teaches us new things. This was very difficult to manage patient who was having hypertension for almost 18 years, and she needed 9 drugs to really control her hypertension, but it was not being controlled. On imaging, there was bilateral glands bulky. On AVS, we could lateralize it to the right side, and patient was treated with surgery. And histopath turns out to be nodules are there. We have a follow-up of almost 6 months. Let me share you what was the details. So post-op day 5, she was improved, and the BP was well controlled only on a single drug. But in a month's time, we realized that the blood pressure was increasing, and she needed to be instituted on multiple drugs. So she needed almost 3 drugs to really control her blood pressure over 4.5 months period. So it means that it was initial cure followed by resurgence, and this is a case of bilateral pathology with predominant secretion from one side. Means that the right one was dominant, and it was a bilateral hyperplasia. The right one was dominant, and after removal of that, the left hyperplasia took over, and finally she was uncured post surgery. But the dent to the aldosteronism has been made because of surgery, and the dosage of medicines have come down from 9 to 3, and she needs lesser drug, and the quality of life is better. That's why people are thinking of using surgery in case of bilateral kind of lesions is a message which can be taken from there. So when you talk of management, if you have a unilateral disease, it has to go for unilateral adrenaline because the treatment is gratifying with clinical success in 84% of patients, biochemical success in 98% of the patients. And if you have a lesion which is localized on one side, then that's the best candidate for going for surgery. Let's see few patients where what we have learned after going ahead with the surgery. So this lady has biochemical evidence of primary aldosteronism. On imaging, there was a single nodule there. On evaluation, she also had an ODS cortisol which was high. So this was a case of primary aldosteronism with Cushing syndrome, which is called as Cushing syndrome. It's important to know these conditions because when you operate the patient can go in post-op aldosterone deficiency as well as cortisol deficiency, and that needs to be taken care of. When she was operated, she went through a creatinine, pre-renal azotemia. On evaluation, her aldosterone was low and cortisol was quite all right, suggesting that this was a subclinical Cushing's and it was not really adrenal insufficiency, and this is transient aldosterone deficiency, which were treated with oral fluids and salt, and over a period of a month, the creatinine came back to normal. With this, you can have a stormy course of such patients, where in this particular patient, elderly individual who had diabetes and hypertension for 6 years, and he was found to have left adenoma. Post surgery, he had a very stormy course. He had to be admitted in the ICU for hyperkalemia and was treated with fludrocortisone. He is under follow for almost a year and a half, and there was suppression of aldosterone or hypoaldosteronism post surgery for almost a period of a year post-op. So underscoring that these needs to be monitored and looked for, and appropriately treatment should be instituted. This is a reality. It could be a transient, or it could be a kind of a prolonged mineralocorticoid suppressions. So what are the factors which can predict post-op hyperkalemia? Is old age, baseline low GFR, larger mass, and longer duration of hypertension, which can predict that. So we have a post-operative monitoring protocol in our hospital where we do monitoring daily with blood pressure, potassium, and creatinine, almost an alternate day for the first week, and then once in a week there. Post-op, we document that patient has cured with lower aldosterone levels and normalization of the renin concentration. Liberal salt and water intake has been instituted. Avoid dehydration and renal toxic drugs is what needs to be done. When we talk of bilateral disease, it's majorly medical therapy with mineralocorticoid antagonists, the salt restrictions, and maybe trimethoprim and amyloid is one of the treatments which can be added on. So let's look at how do we really optimize patients of bilateral disease which require mineralocorticoid blockade. So this was a patient who was put on spironolactone and post on an amlodipine, and post starting that renin was done. Renin was kept in the higher range or in the normal range. That's what has been advocated when we try to treat patients of mineralocorticoid receptor blockade. What has been shown in this elegant study is that they looked at patients' cardiometabolic outcomes and mortality in medically treated patients. They've compared that those with essential hypertension. It was very clearly shown that if the data is compared with surgery for unilateral adenomas, surgery is the best. But when it comes to medical therapy in bilateral part, then the the adjustment of dosages of mineralocorticoid receptor antagonist therapy, which should be adequate, is based on strong clinical follow-up, as well as potassium, as well as renin monitoring, which needs to be done. And we need to keep the renin in the normal range. If you keep in the renin in the lower side, that means the mineralocorticoid receptor blockade is not adequate. Then the cardiometabolic outcomes are really not that good. But if you keep it in the normal range, then the cardiometabolic outcomes are equivalent to that of patients who have been treated with essential hypertension. So all this while we have been talking of severe kind of primary hyperaldosteronism, where there is clinical picture, it's an overt PA, hypokalemia and severe hypertension. But more and more patients belong to this mild hypertensive or a normotensive PA cohort. And there have been data as well as literature showing that even normotensive patients who have not yet gone into hypertension have a syndrome of renin-independent aldosteronism. So it's all a spectrum, continuum from a subclinical primary aldosteronism to an unrecognized yet biochemically overt PA to an overt PA. And at least we should start looking at this overt PA in our Indian scenario. But definitely there is a case which needs to be made for looking at milder hypertension as well as those who have signs and symptoms. And that's what we need to look at. Dr. Anand Vaidya and William Youngs are expert in this field, and they are linked to health policy or issues also. So we know that there are so many patients and they may not come to so many experts. And so physician needs to really look at it. It could be simplified by just doing a plasma renin and aldosterone value. And if it's less than aldosterone is in the phase of renin suppression, aldosterone is more than 15, it really goes to the experts for managing. Less than 5, patient it does not have PA, and 5 to 15, then at least the patient should be put on mineralocorticoid receptor antagonist so as to improve the cardiovascular outcomes in these patients. And those patients who progress, they may be looked for various further PA evaluation. So to summarize, I have talked about the diagnostic aspects of it. We don't need to stop the medications. Do a renin, do an aldo. If renin suppressed, aldo is high, more than 10, we can reach there. Expert centers, we need AVS before really going for managing these patients. And the treatment with MRA is really important to be managed with renin monitoring and potassium monitoring. Surgery is a treatment of choice for unilateral cases. With this, I would like to stop and thank you for your kind attention.